Welcome back to lecture. Before we were talking about the ear and all the different kind of the anatomy of the ear, different functions of those parts, and then we got into some surgical procedures. Right? We talked about a little bit about the draping for ear procedures and prepping, making sure that the betadine never gets down into the ear canal and onto the tympanic membrane because it's toxic. Remember, betadine is toxic to the eardrum. We'll talk about some of the instruments, things like that. But now today we're going to talk about the rest of ENT, the nose and the throat. So first we'll kind of start here with the mouth. Try to get everybody's here on the list. So the mouth plays a role in ENT, right? There's some surgical procedures that we can do in there and stuff on the ENT side of it. Most of the things, if there's like a fracture or something like that, then an oral surgeon is going to handle that. But anything that's like soft tissue related, like the tongue, the tonsils, uvula, soft palate, that kind of stuff falls into the realm of the ENT surgeon. Knowing some of your oral cavity, right? Here's that hanging ball is your uvula. Right? This is the soft palate here where if you push on it from underneath the roof of your mouth, if it doesn't feel like there's anything hard behind it, then that's the soft palate. And then if you feel like there's a bone, the maxilla, then that's the hard palate. Of course, you got your tongue. It helps to know some of these teeth. Right? You have your bicuspids, tricuspid, then remember your incisors are the sharp ones, that kind of like your vampire teeth. Those are the ones that are meant to really rip into tissue and pull apart. Next one. So then in the nasal cavity, like most often you're thinking about your sinuses. You have your maxillary sinuses, your frontal sinuses up here, a few others like sphenoid sinuses that are kind of deep, and things like that. Basically, the things that you need to kind of understand about the nose, the nasal cavities and stuff, are the turbinates and the nasal septum, because that's typically for ENT surgery the things that we're dealing with the most. Is we're either trying to reduce the size of those turbinates because as they swell up, that takes up room in the nasal cavity, making breathing, making you feel that congestion and stuff. So you reduce the size of those turbinates, and then also you can realign the septum to help with airway passages and the movement of air throughout the nasal cavity. Trying to think of there's a whole lot else. And the other thing to note is what is the function of the nose? First and foremost, for smelling, right? And then additionally to warm the air and filter the air that you're breathing in. Right? That's what like your nose hair and stuff is for, is to catch those dust particles and things like that to prevent them from getting into your lung and then maybe potentially causing like a pneumonia or some kind of infection or something like that, or even like a systemic type infection. Some diagnostic tests that we can do. We can do endoscopy into the nose. We can put a scope, do it like a sinusoscopy. We can even put them into the back of the throat, where we're looking at the larynx or even down into the trachea, looking at the bronchus, doing bronchoscopies and things like that. Making sure this isn't. And then we can do operative procedures, diagnostic, right? We can do endosinus surgeries, maybe even do like some biopsies, things like that, all through putting a scope in the nose and looking up into the nasal passages to see if there's any like polyps or growth, or the turbinates are swollen, things like that. And then of course we can go back to the X-ray department and do MRIs, CT scans of the nasal sinuses and things like that to get an idea of what potentially could be going on that's causing the patient problems. Sorry. Prepping and draping, right? We're working on the face. We're going into what's considered to be a dirty area into the nose, right? That we're going to call it a clean procedure. And the reason that there's the difference between the name, dirty and clean, is that if you're doing the procedure and treating it as a clean procedure, then you're adhering to as much aseptic technique as you can. You're still trying to keep sterile with sterile. Just the problem is, as soon as you use that instrument in that area, that instrument is now no longer sterile because it's a dirty area. But as long as we just keep using that instrument on that area only, then we're not transferring microbes and bacteria and things from somewhere else and introducing it into an area that doesn't have that bacteria already. It's the same thing when we're working, question mark? It's the same thing when we're working like down in the anus, right? If you're doing hemorrhoid surgery and things like that, you're still working in a dirty area. Or if we're working on the vagina or on the penis or something like that, we're still working on a dirty area. But as long as we're only using those instruments in that area, and we're not going to use those instruments on another part of the face, or take a lesion or a skin tag or something off the inner thigh and then take that instrument and put it back in the vagina, that's how we can transfer microbes, because there's normal microbes that live on the skin, right? Staph aureus. If we use an instrument to take a skin tag off of that area and then took that instrument and put it in the vaginal canal, now we're taking Staph aureus from that skin area and introducing it into the vaginal canal. But if we never go anywhere else and just stay in that dirty area with those clean instruments, then we're not transferring microbes. Right? We'll still do a head drape when working like on the nose and stuff like that. We want to keep that hair from getting into our surgical field. That's where we're using that 3/4 sheet with the 2 towels. So there's a question on the chat came up that's asking, if we use a dirty instrument, or if we grab a bloody instrument, would we be considered contaminated? There's tricky work here, tricky wording that's coming into play. So don't focus so much on clean, dirty, contaminated. What you want to focus in on is that we're using those instruments on that area. That is the only area we can use those instruments on. And as long as we're going in and out of the nose, or in and out of the mouth, in and out of the ear, in and out of the anus, in and out of the vaginal canal, in and out of your urethra, then we're okay. Because that instrument is just in that spot. Whatever microbes it picked up from that spot, we're already there. We're not introducing anything new into that area. And that's where contamination would occur. That if, let's say we were doing a septoplasty and a hemorrhoidectomy on the same patient, never going to happen, but let's say we were. We would not use any of the instruments that we used for the hemorrhoids on the nose, including needle holders, pickups, any of that kind of stuff. And so you would probably have two separate setups. And so there's a question in the chat about what would we do in the case if we needed like a skin graft and we were working, like we were doing a septoplasty, but the patient also had some kind of lesion on one of the nares of their nose. Taking that lesion off, we need to bring a skin graft over. You would have a complete separate set of instrumentation and more than likely have a whole nother table, because the site that we have to go and get that graft from, that would be a sterile site. So we would need to be completely sterile for all of that. And then where we're taking it to would be a clean site. I know I probably just confused more than half of you, way out of your minds. It's it's why for like myringotomies, you don't have to put a gown on. You just put on a pair of sterile gloves. And it's considered a clean procedure because we're using all of those instruments on the eardrum and we're accessing through that ear canal. We're not using those instruments somewhere else and then coming back. So it's okay to be that way. So do your aseptic technique that way. There's a question. So what about in other cases that's not? Oh, so like, you're just talking about like a regular case where instruments get blood on them, and if we grab that instrument with our gloved hand, we are not contaminated because that blood came from that patient. So if there's any microbes in there or on that blood, that patient already had it. We're not introducing anything new to that patient. Does that make sense? So technically, the minute that you take the lid off of your instrument tray, in the most strict of senses of sterile and not sterile, as soon as you take the lid off of that tray, that set is technically contaminated through little microbes in the air, things just falling down into it. But there's no way for us to keep everything that we have on our table 100% microbe free, only because there's going to be stuff in the air. We do the best we can in terms of that air pressure in the room, right? That negative airflow or positive airflow, where we're constantly pushing air out, right? Then we have the HEPA filters for our ACs and stuff like that try to filter out as much as possible, but we're never going to get everything. So when we're working on a patient, you're going to get blood on your hands, you're going to get blood on the instruments, blood on your gloves. And if you need another instrument from your back table and you have bloody gloves, it's okay, because that blood belongs to that patient. So they're already used to like, I guess, if for lack of a better word, the contaminants within that blood. That's already a part of that person. Does that make more sense? Some equipment, different kind of instrumentation that you might see. Here's that microscope back, right? If you're looking down into the throat, into the larynx, doing microlaryngeal type procedures, you'll be using this microscope because you need to see the small structures of the vocal cord and things like that. Suction cautery, this I talked about with the tonsil, right? Also can be used intranasally as well. Sinuscopes, a microdebrider. I don't know. I think I showed Group B. I hope Group C got to see this. That's that little shaver thing that I showed you. That you put that in the nose, and then it's got the two pieces to it. One outer sheath over the other, and the inner one you spins, and it's got a little sharp tip on the end, and it'll cut tissue, but you also have suction hooked up to it, so it's sucking that tissue into it as it's cutting it up. You can, debride turbinates that way. You can, like reduce the size of like polyps, things like that inside the nose. And then you guys have seen the TNA instruments in the tray. Right? Typically, for these sinuscopes, they're going to use a 30-degree 0 and a 30-degree scope. It's going to give them the most visualization inside the nasal cavity. Some medications, right? Anesthetic agents like local, typically things with epinephrine. You'll also, the patient will, prior to coming to surgery, use some Afrin nasal sprays. And then we also may soak some of the cottonoids, the 1/2 inch by 3 long cottonoid sponges, with the 4% liquid cocaine. All of these things are in an effort to get vasoconstriction to happen inside the nose. The nose, along with the face and the head itself, is a very vascular area. So, any hit, you're going to see like a lot of bleeding. So in order to get all those tiny blood vessels to constrict and to have very little bleeding is why we do, epinephrine, the cocaine, the Afrin, all that is to try and get those blood vessels to shrink up as small as possible. So we make incisions or we introduce, instruments and things into the nose, we don't stir up a lot of blood and bleeding. That's going to now block our visualization. But here's some endosinus surgery and reasons why we're doing it, right? We're taking out polyps. Maybe we need to make an opening into the maxillary sinus to allow for some drainage. The patient's having like chronic sinus infections and things like that. So a lot of that tissue in there is swollen and it's trapping fluid and things like that, causing that congestion. Maybe we're taking out a piece of the ethmoid bone. Again, to allow for drainage and circulation of air throughout the nasal cavities. Right? Same thing up in the frontal sinus. Maybe we're trying to clear out some kind of infection. When there's some polyps that may have grown and are blocking airways, right? Trapping air within the nasal cavity, and some of that air has microbes in it that's causing these infections and things like that. And if we're going after the ethmoid, we might be going after the sphenoid as well, and kind of trimming back some of that bone because it's causing a blockage somehow in the nasal cavities. But this is what it looks like externally on the outside of the patient. Right? We got a camera with a scope. We're shoving it up their nose. Right, we got all these cords coming off. We've got different suction cords and irrigation tubings and things like that to kind of wash out inside of the nose while we're working. But then this is what it looks like on the inside. And what you see here, that's not a booger that's being sucked up. That's actual tissue inside the nose. This is a nasal polyp that has grown inside the nose. And what they're doing is the suction is providing like the tension. The suction is acting as almost like your grasper. And then they can go in with a rongeur type instrument and then clip and cut that polyp, and then the rest of it sucks up into the suction. Because you are working in kind of a small hole, right, going through the nares. So it's not as easy to put in two instruments that are working type instruments. It's easy to put in a small suction, and then you can reach in with like a grasper or cutter and cut away tissue. Looks like we're going to get into, we're getting into some of the procedures now, working in the nose or in the sinuses area. This is a Caldwell-Luke procedure. What you're doing is you're actually going in through the mouth, and you're going to make a hole or an incision into the gum line up by the maxilla, above the upper teeth. And then you actually will punch a hole through the maxilla of the bone there, and that gives you access now to the maxillary sinuses. Some complications of this would be some like bleeding. Bleeding is always a complication of any surgery. But infection is another big complication because we made this incision in the mouth. And the mouth is one of the more dirty areas of the human body. So without proper care and maintenance by the patient post-op of this can lead to a pretty bad infection, not only of this incision site, but also of the maxillary sinus.
Question.
Yes.
For procedure like this one, like the cat, mouthwash is something similar.
Yeah, typically the prep for this procedure is like a Listerine mouthwash with a toothbrush.
Got it.
So they'll soak that toothbrush in the Listerine and scrub the patient's teeth and mouth with it. Now you have you can do like turbinoplasty. That's the name there for a turbinate reduction or a turbinectomy. You can even completely remove some of the turbinates, but you have turbinates throughout the nasal cavity, and their main function is to warm the airflow when you're breathing it in, and so you don't feel like real cold inside your chest, because normal atmosphere, air is cooler than it is inside your body. So as you're breathing it in, you're kind of warming that air up. It's also acting as kind of a filter for particulate things in the air. Your hair the nasal hair does a lot of that too, where it's catching like the bigger particles, and then the turbinates are supposed to catch some of those more microscopic type particles. But this is usually done in conjunction or at the same time you're doing a septoplasty. You're also doing usually it's a septoplasty with turbinoplasty. That's how the case will be booked. And then here's your septoplasty, right? What you're trying to fix a deviated septum. So the nasal septum should be straight down. If you look kind of at me, you can tell mine kind of moves off to my left. My whole nose is kind of a little bit off to the left-hand side. But if I put my piece of paper, If I try to make it symmetrical with like my eyes and stuff, you can see more of my nose on one side than the other, and that my septum's a little off. Um, Typically, the reasons why we do a septoplasty is to deal with like a sleep apnea, right? Snoring, things like that, is to help kind of correct uh, that problem. Um, and it could also be, could cause, if deviated too far off, could cause, chronic sinus infections and things like that. Because, let me zoom in on this. So you can see as that here is more of a, this is like an MRI image of it. And this is just kind of a drawing underneath. Uh, but we're changing the shape. And because we're changing the shape, we're changing a little bit of function. And if this, like this septum is deviated to the left, so pushing it this way to the left is now going to close off some of that sinus space. And it may kind of close up a little bit of some of those passages where the air comes in. So it may not be as easy for that air to escape as well. So you're going to cause, trapping of air that has microbes in it that could lead to those chronic sinus infections and things like that. Or you could be pushing on other tissue so that when you sleep, now that tissue is kind of off to one side. That's now putting pressure on the back of your palate, causing that snoring, that sleep apnea, which then now you're not getting good sleep, which is leading to fatigue and tiredness. And keeps perpetuating itself and getting worse and worse. So what they'll do is they're going to go in and they'll actually make an incision inside the nose. And then that way they get right up against the septum. And then they'll use little osteotomes, basically like chisels, and make little corrections in the cartilage of the septum, and then get it to straighten back up. And then they close everything up, and then they're going to put a splint on the outside of the nose that holds it in that straight position while it heals straight. And then after about 4 to 6 weeks or so, the splint comes off, and you really get to see how they did. And you should have a good, up to that point though, there's like packings and things and splints and stuff that they also put internally to help keep it all in alignment. So probably about the first 2 to 3 weeks post-op, you become like a mouth breather because you've got a bunch of stuff packed inside the nose to help keep it in that shape. So you're like, that's how you learn or adapt to breathing. And then once everything comes off, you're like, oh, wow. Like you really notice the difference. Well, that I speak from personal experience because obviously I haven't had a septoplasty. Rhinoplasty, typically a case that's reserved for plastic surgery. However, some ENT surgeons can do it as well. But most often you'll find a rhinoplasty being done by a plastic surgeon because this is a cosmetic repair of the nose, of the external nose. Okay? Can be done, like I said, by an ENT surgeon. ENT doesn't typically do these procedures because it's not something that will be reimbursed by insurance. Insurance is going to reimburse these doctors for cases that have a medical need. If the ENT surgeon can show that there's a medical need for doing a rhinoplasty, that it's affecting airflow, or it's causing infections and things like that due to shape and functionality and stuff, then the insurance company can approve it and give like a reimbursement for it and go ahead and cover it for the patient because there's a medical need behind it. If it's strictly cosmetic, then it's plastic surgeon, and that patient is going to have to pay for the entire procedure out of pocket. Rhinoplasty. I want to say that this is not the same person, but it might very well be. Sometimes those before and after pictures, they try to trick you. Tonsillectomy. So this is what is referred to as kissing tonsils. It means that the tonsils are so big that just looking in the back of the throat, you can see that they're touching one another. And then this is what it looks like after the tonsillectomy has been done. So these areas right here, this is what they call the tonsil bed. Is where the tonsil lies. Why it's all black and kind of gross looking back here. This is where the suction cautery burned the tissue to stop bleeding and burn the tonsils off of their bed and out. Sometimes they can use that Crow-Davis retractor or the McIver retractor during tonsillectomies to hold that mouth open. The Crow-Davis is the one that's got the two pieces, the tongue blade. I'm sorry, that's not the Crow-Davis. The McIver is the one that's got the two pieces where you hook the tongue blade up to it, and then you put it in the mouth, and then you dial it up, and then they latch it on to your Mayo stand to help hold it in place. But some of the reasons we take them out is because you've had chronic infection. Typically, what makes you a candidate to have your tonsils removed is if you've had strep throat 3 times or more in one calendar year. Usually on that 3rd time that you get it, that's when they start, your general practitioner doctor will ask you or start talking to you about maybe a referral to an ENT surgeon to maybe think about having these removed. Typically, we're going to do it in kids, but can be done in adults. It's a much worse experience, I hear, as an adult, because you remember that pain a lot more, and it takes a little more for you to get past or get over the surgery and recover from it as an adult than it does as a child. Also, probably because as an adult, we as adults were like, oh, it's fine. You know, I don't need to go to the doctor yet. It's okay. Whereas a kid, you know, you're as a parent, you're going to be like, oh, and you're going to be more worried about your child, and you're going to be more prone to take them in and get them looked at and taken care of than you will yourself. It's just kind of a natural human. So, your adenoidectomy, this is usually done in conjunction with taking out the tonsils. But you can see right back here, your adenoids live right behind that soft palate. Let's see if I can't get back to the mouth. There we go. So this soft palate right here, you got your tonsils right here to the either side of it, but then right back behind this soft palate is the adenoids, which is why they'll put in that red rubber catheter through the nose and then back down out through the mouth, so it helps pull this up, kind of helps pull this soft palate up a little bit and gives you access to those adenoids and being able to scrape them off and scrape them out. Also, a way to help treat sleep apnea is to do what's called a U-triple-P, or a uvuloplatopharyngoplasty. It's easier to say U-triple-P, right? This is a last-ditch effort to correct sleep apnea. Usually they start with the septum and doing like a septoplasty, checking all that. And if you don't have a deviated septum and there's nothing wrong with your nasal passages and things like that, that's not the cause. Then they're looking back in the mouth and in the back of the throat at like your soft palate and uvula and stuff like that, and seeing if taking some of this tissue out and opening that space up will help prevent some of that from relaxing and going down and covering over the airway. And that's what's causing the sleep apnea, is that those tissues, when you fall asleep, are all relaxed and they fall down, and like your tongue even goes back up against the back of your throat, kind of closing off the airway, or making it very narrow. And that's that sound of the snoring you're hearing, is that air passing through kind of a narrow passage to get back into the throat. So you're hearing that, right? Well, and then as that tissue even relaxes more and goes down, it's going to cover over the airway. And that's when they're like, and there's actually no breathing going on for a short time, then the body realizes, hey, we're not getting the oxygen in. And that's, you kind of partially wake up. And that's where the fatigue and stuff starts to come into play, because you're not getting good sleep. You're not getting to that REM sleep, because you stop breathing, and then the body has to kind of wake you up to breathe again. We may also have a trach setup or a trach tray on standby in case we can't intubate these patients, because they have such a small opening here. We may not be able to get an endotracheal tube in easier. We may not be able to see all the structures we need to see and get that tube placed properly. So we may have to do a trach on those patients so that we can even access that area. Laryngoscopy, you have indirect and direct. A direct laryngoscopy is you're going to use the laryngoscope. Anesthesia does direct laryngoscopies every time they intubate a patient. An indirect laryngoscopy reverse those, I'm sorry. Indirect is where you're going to use the laryngoscope. So this is the actual scope here, the real small diameter one that's going to go down. You can go through the nose, you can go through the mouth of it, but if you're actually going to look directly at the vocal cords without using the laryngoscope, now that's a direct visualization. And this is what the vocal cords look like when using the laryngoscope. This is what you see. So this is where they're trying to put that endotracheal tube. It's right in here, right in between these. Here's tracheostomy. Right, you guys got to see the trach in lab. I showed you this the trach here, and then the obturator, and then the internal sheath or internal cannula. The obturator, this gets placed into the trach when you're initially putting it in. The obturator will be removed and then replaced with the inner cannula here. The obturator must be cleaned off of any blood and fluids and stuff that's on it, and then given to the nurse to be taped to the patient's chart. This must always be with the patient. In case this ever comes out, then they can put the obturator in and put it back in. Because if this ever comes out, then the patient's not breathing. Right? But this is what you would do for a trach. But you're actually going to make an incision into the neck, dissect down so that you're exposed the trachea, and then actually cut into the trachea, and then shove that tube into the trachea. Shove this into the trachea. Usually, like I told you guys this, we're putting in a trach for a patient who's going to be like a long-term resident of the ICU. Because if we leave a tube down them, we're inviting an infection and pneumonia into their lungs. So putting the trach in, now it's a more sterile. Neck surgery. So typically, if we're doing anything in the neck, most of the time it's for some kind of cancer or removing the thyroid or the parathyroid glands. But there's a lot of structures, very vital structures, especially to the brain, that live here in the anterior part of the neck. You got your carotid artery, your jugular vein. The thyroid itself plays a huge part in metabolism, right? It's releasing its thyroid hormones, T3 and T4, that help convert, iodine and things that the body needs for these metabolic processes. So we have to be very careful in this area. We got a lot of nerves in there also that are going to help with like muscle movement and vocal cord movement, a lot of those kind of things. So there's a lot of things that we have to be very careful of in the neck. So a lot of times when you're doing dissections and things in the neck, those cases tend to take a long time because they have to be very careful and very meticulous about what they're cutting into and what tissue they're saving and things like that. Typically, the patients are going to be supine for most of your ENT cases. Draping is going to be a little different. If you're working on the neck, there's a thyroid drape that has a diamond-shaped opening right in the middle. So you're just going to put that, just like you've been doing with your lap sheets and things like that, you're just going to put that opening right over the neck, lay it down, and then open up head to toe. Typically, if you're doing something like on the face, things like you may be doing that head drape where you're wrapping the towel around and making the turban. But it's all going to be about maximizing the exposure for that area. Yes.
When it comes to the neck surgeries and everything, is the head bent like slightly like tilted, like the head chin tilt lift kind of deal?
Yes.
Close it?
And usually what they're going to do is put a what's called a shoulder roll behind the patient's shoulders, and just lower than the patient's shoulders, and they'll lay on that, and that causes the head to naturally just fall back, and it lifts the jaw and gives you more access now to the neck. It's kind of like you looking up, and kind of stretching out that neck and giving us more space to work with in here. You'll still like square off with towels in this area, but you may take the towels on the sides that are going to be here on the sides of the neck and make balls out of those towels. Just kind of like bunch them up and make a ball, and you'll stick the whole ball there. Because if you try to put a towel there, that towel is just going to kind of like fall down to the bed and then leave the back of the neck kind of exposed areas that we haven't prepped. But if you put the ball there, then the ball gives more like a more substantial thing to that area. Does that make sense? I'll show it to you guys in lab too. But
yeah, I got you on that one.
And then, different instruments, right? You're going to have elevating type instruments, speculums, self-rotating retractors to hold like the mouth open, those kinds of things. And then dressings are going to be different depending on what you're working on, right? If you're working on the ear, you're using that big glass cock covering. Right? If you're just doing myringotomy tubes, then you're just using cotton balls to plug the ears with. If you're doing like nasal surgery, you might be putting a splint on the outside of the nose and putting some splints inside the nose. You may also do some packing inside the nose, things like that. If you're working in the mouth, typically not a whole lot of dressing going on inside the mouth because it's all mucosal membrane. Same thing inside the nose, right? The packing is there just to help give shape to the nose and to keep that septum straight. And also to kind of like soak up blood and things like that as because as those medications and things start to wear off, those vessels are going to kind of dilate again, and you may have still some oozing of blood later on. That's also the reason why they do the packing for the nose. And a lot of medications are going to be based on trying to prevent a lot of bleeding. So you're gonna be doing things with epinephrine in them. Where in the nose can we not inject anything with epinephrine?
Near the sinuses?
The very tip of the nose. Because if you inject anything into the tip of the nose, the blood vessels in there are so small that if you force constriction on them, the actual tissue of that blood vessel itself won't be getting any oxygen or nutrients. And even in that little bit amount of time, for like the 4 hours it takes for it to wear off, those blood vessels will die. And then the tissue at the tip of the nose will then subsequently die because now it's not getting any of those oxygen and nutrients. There's a few places, fingers, toes, penis, and tip of nose are the main areas where you never inject anything with epinephrine, because the blood vessels in those areas are so small, you're going to kill those blood vessels, which will kill the tissue.
Would the clitoris be the same?
I'm sorry?
Just because I say, would the clitoris be the same, or is it because it's like?
I believe so. It's just I haven't really done a whole lot of surgeries where we're just working on just the clitoris.
Because mostly that's plastics.
Yes, yeah. And I think even like vaginal rejuvenation, I've seen GYN surgeons do that too. But they have to go to like a little special plastics kind of training to learn how to do all that. Because typically females, when you build a relationship with your gynecologist, right? And it gets to a point where you only trust your gynecologist down there. And you don't want to go see a plastic surgeon who, yeah, you work on boobs and butts, but I'd rather have my gynecologist deal with my lady parts down there. I don't know. It could be different. It depends on the patient. Depends on their relationship with their gynecologist. We may have to go after the submandibular gland. We may have to go after the parotid gland. If we're doing any of that, we're making incisions on the outside, which means these are sterile cases. But we may have to take these out because what does this gland do?
Saliva, right?
Saliva. It's one of your salivary glands. Yes. So it may get a stone formed in it. You may be getting like an infection in it somehow. It may have a cancerous tumor. Most often, it'll be for like a cancerous tumor. They tend not to want to take out your salivary glands unless they absolutely have to, because then there's a whole another slew of things that the patient has to deal with afterwards, because now you've lost a salivary gland. So you may be dealing with like dry mouth, things like that. So there's your thyroidectomy. With a thyroidectomy, one of the things to understand and know about your anatomy is that the parathyroid glands, does anybody know how many there are?
4.
There's 4. And they live right on top of the thyroid gland. There are 4 little ones. They sit in like a little like square kind of pattern. So 1, 2, 3, 4. Does anyone know what the parathyroid regulates? What is its job?
The amount of calcium in the blood.
Exactly, your calcium levels. So if your calcium levels are low, the parathyroid releases parathyroid hormone telling the body, hey, we need more calcium, break down some bone. If you have too much, then it sends out the signal, hey, we got too much, start getting rid of some, send it to the kidneys, where you could potentially form a calcium stone in your kidney. But when taking out the thyroid, they have to identify those parathyroid glands and free them up off of the thyroid so that they can be left behind. Or you're going to cause now a problem with calcium levels in the patient. Also, the other thing in thyroids that they're looking for is the recurrent laryngeal nerve. There's a special tube called a NIMS tube and a special machine that you have, the NIMS machine. It's a nerve monitoring machine. The endotracheal tube that goes into the patient has special sensors down near the cuff, where it's going to be down here in the neck closest to the thyroid. And then you're going to have a special nerve stimulator probe on your field that hooks directly to the NIMS machine. And they're going to poke around a tissue trying to find that recurrent laryngeal nerve. Because if you accidentally sever that nerve, you're now directly affecting vocal cords and speech, your ability to speak. So it's why they have to identify it and make sure that they don't cut it, and they can remove the thyroid without cutting it. The recurrent laryngeal nerve travels right back behind the thyroid and is sometimes through tissue and everything attached and stuck to the thyroid. So you have to be very careful and meticulous in your dissection of getting that nerve off. This is the old school way that you're seeing here, where every little bleeder inside the neck and around the thyroid, they had to clamp, cut, tie, all of that. Now we use the harmonic scalpel. It's a smaller one. You got one that's like this big, little small handheld one that you can just go through right through all of that stuff. And now where this procedure used to take, 2.5 to 3 hours to do, now takes 45 minutes. Really nice and easy. Peels right up off and out. And you can take out half of the thyroid. You can take out the whole thyroid. You can take out just one lobe. One of the things to, let me see if I can't bring back up. Okay, good. So here is the thyroid right here. This pink tissue you see under all these veins, and it looks just like this. So this would be the right lobe, and this is the left lobe. And this little piece in the middle that connects the two lobes is called the isthmus. I-S-T-H-U-S. No, isthmus. I-S-T-H-U-M-U-S. Isthmus. So if you're just taking one lobe, you're going to leave this isthmus and this other lobe. If you're taking the whole thing, you're going to take both lobes plus the isthmus.
You said that you would take the isthmus with the lobe that you're taking, or leave that one behind?
It depends. Sometimes you can leave the isthmus behind with the lobe you're leaving, or you can take the isthmus with the lobe you're taking. Some of it's going to depend on symptom of the patient and what the thyroid looks like when they get in there. If there's cancer in one of the lobes, has it spread, that kind of thing.
Okay, and would you consider the thyroid to be as vascular as like the spleen or liver, or is it like a little less?
Little less, but because it's in the neck, you're going to have a lot of vascularity in that whole area. This is also the area for when they're doing dissections that they're going to use the kidneys. The kidneys get loaded onto a Kelly clamp. And the Kittner is just a small little ball sponge that's got a little X-ray detectable strip in it. And you're just going to load that on the very tip of the Kelly clamps. And then they'll use that as their blunt dissection in the neck. And then that brings us here to the neck dissections. This is going to be a much more involved. You'll make a similar incision that you do for thyroid surgeries, but now you're going to undermine all that skin and look at all of the structures of the neck. Typically done for cancer, and you're trying to go after all the lymph nodes and all that stuff. And it's a very long procedure because you have to be extremely meticulous in freeing up all of your blood vessels and nerves and things like that, really trying to get as much of that cancer out of the neck as you can. Especially before doing any kind of like radiation type therapies and stuff like that. Because after doing radiation and stuff for that cancer, you're going to build up a lot of scar tissue. And then now it's going to be even much more difficult to determine, okay, what's nerve, what's scar tissue, what's, things that I need to leave behind that the patient needs versus what can I actually dissect through. But that marks the end of ENT. Does anybody have any questions over the ear, nose, throat, any one of these procedures? How about any questions other than that? Comments, concerns? Queso, anybody want any cheese? It was thought today in lab that I said queso. And I forget what I actually said, what I was actually talking about, because we went off on a super tangent about cheese. Case over. That's what I said. Case over. I did not say queso. I said case over. Anything else? EALs? No queso, not today. Make sure we're doing our EALs. Right? We should be, chapter 26 is going to lock out this week. Oh, I know what you guys want. You want the code to the quiz. I know what you want. Let me grab that real quick. Make sure you guys are doing your initial posts of your discussion boards. If you haven't done it for this week, I would suggest quickly do it before it locks you out if it hasn't locked you out already. Your code is coming in the chat. Make sure I do it right. And there's your code for quiz number 7. We are in week 7 now. There are only 3 weeks left of this term, and 15 weeks until clinical. How many harps just skipped a beat right then? About time to see some real blood, right? Some real knives cutting on people for real. What else? So not next week, but the week after. Field trip, we'll have to get with Ortiz on that. He's the one that coordinates those field trips. So when he comes back from vacation, Okay with them. Let's see, not this Friday, but next Friday, we're doing the brains in open lab on the 30th of July. We'll be working on brains, dissecting them and stuff. I was going to give you guys some advice. I forgot what I was going to say. Oh, yes. So not this coming Monday, the 26th, but the following Monday, the 2nd of August, the immunization people will be back on campus. Or maybe it's not Monday the 2nd, it's Tuesday the 3rd of August. Like I've said before, I can't confirm or deny whether or not that'll be the time for your drug test, but it very well could be. And then, of course, anybody that needs anything else, like TB tests or any final vaccinations and that kind of stuff, that'll be taken care of that day. So make sure that you're available to come August 3rd. That's a Tuesday at either 11 a.m. in the morning or at 5 p.m. in the afternoon. I'll remind you again next week, but just so you got the heads up that it is coming again. They'll come back again, I believe, the first week of September and the first week of October as well. Let's see, you guys start clinical November 8th. So yeah, the last opportunity for you guys to get your immunizations and all that stuff squared away for clinical will be October 5th. So either August 3rd, September 7th, or October 5th will be drug test day. And I don't know which one it is. And I do not believe that we're going to give you that kind of heads up. So be prepared. And if nobody's got any questions, comments, concerns, enjoy the rest of your day. Make sure that if you haven't done your discussion board, get that knocked out. Code for the quiz is there for you guys, and I will see everybody tomorrow, or those who are here tomorrow.